when do you look into yourself and say, I can be better? And that's the whole different argument than forcing doctors to accept someone else's treatment, is to say, how can I look at myself and just be a better dentist, and what would that entail? And so I think that's the first step, is to get doctors to think inward and say, if I was a better doctor, how would I think my own pattern of practice would change?
Welcome to episode number 6 of Dental Riffs, where we talk about everything in the dental industry. And recently I was posting online and I had a conversation that came up and several doctors commented on it. And I'm excited about this conversation today because I think it's one that needs to be had. And Tanner, why don't you kind of frame the conversation that we're going to have today, and we'll go from there.
Awesome. Yeah. So Gary, in earlier episodes, and I think it's been a reoccurring topic that's popped up a lot during our conversations, right, is what is this idea of standardization, or these like parameters or perceptions of like, okay, what is ethical, what's not ethical in dentistry? And you and I have kicked it around a lot, but I think that obviously neither one of us being clinical, we wanted to bring somebody on who we felt like was an expert in this and help us frame it out a little bit more. I mean, it seems like this is one of those topics that it may never come to a full answer, but we definitely just want to kind of keep that conversation going publicly, and would love to kind of push that forward a little bit. So we brought on Dr. Matthew Gillespie. Matthew, you want to go ahead? I'll call you Matt throughout the rest of the episode if that's okay with you.
Yeah, that'd be great. So I'm a dentist in Tyler, Texas, just outside of Dallas. I focus on minimally invasive dentistry. I've just completed a master's of business administration, so completed an MBA, and I'm now in my second semesters of a master's of health science degree due to that interest in quantifying the progression of dental disease based on a doctor, based on a patient, and what that means on for the financial impacts of a dental practice, of the patient side, of the doctor side, and society as a whole.
Awesome. For people like me, who I didn't go to college, so could you just explain like what is health science? What does that exactly mean?
So it's got a broad base of knowledge with a focus on epidemiology, biostatistics, program development, and implementation. And so like in this case, how do you find the best doctor? What does that actually mean? How do you quantify outcomes? Like, am I good? Do I even know I'm good? And how can I even check if I'm good or not? And then how can you take that data, aggregate it, distill it down into something that can be published or something that can be implemented either on a practice, a DSO, or even a larger scale, like of a government insurance program or even healthcare systems in general.
Hey, before we go any further in the show, I need you to visit a website for me, dentalmarketingmanager.com. If you're a dental office that has somebody managing some of your marketing internally, it's so important that you get them trained. And right now, there is no standard, there is no set of KPIs that people use to build out this position. And so it's been a little bit like the Wild Wild West, but we're aiming to change that. On December 8th and 9th of 2022, we are going to be hosting the first ever Dental Marketing Boot Camp, and we're going to be covering everything that there is to know about being a marketing manager, all the KPIs, how to partner with a marketing vendor, how to build out a position, how to get more patient referrals, 2023 plan calendared out, and everything that you're going to need to manage your dental marketing. And this is not something that you're going to want to miss if you are a marketing manager, and you're not going to want to have your team miss this if you have somebody helping you internally with your marketing. So we hope that you will come. A lot of the SMC clients are going to be there. And if you don't work with SMC, that's totally fine. We still want you there. We want to help you. We want to help your businesses grow. So go check us out, dentalmarketingmanager.com. We have limited space, limited opportunities, and we hope to see you there.
It's awesome. This is really exciting. You know, I have, like, as you're sitting there saying that, Matt, I have like 40 million questions pop into my mind. So let's just dive into it. So one of the things I think that we were initially kicked off this conversation is this topic about AI in dentistry, right? So we hear a lot about like these Overjets, Pearls, Videa Health. I mean, there's a lot of these different players coming into the space that are bringing AI into dentistry, having had kind of a multifaceted approach with a business degree, now with the health science degree, also being a clinician yourself. Do you have associates that you work with?
Not currently.
Okay. Okay. And so I'm curious then, kind of what's your perception on this whole AI and AI in the dental clinical space?
I think it's got great potential. I mean, like we were mentioning earlier, so AI has the potential to be able to aggregate a large amount of data from individual practices, distill it down into actionable information in a blink of an eye. The question is what do we do with that information, and what information do we want that AI to gather? And so if we're talking about standards in dentistry, it's something that we don't like to talk about. But once you graduate dental school, you get tested, you take the boards, you get your license. All of a sudden, from a societal point of view, we're expected to think ourselves as exactly the same. I can't even advertise that I'm better because it goes against a state board statute here in Texas, even if I may be. So we now have a group of dentists that we don't know who's the best. We don't know who offers the best CEs. We don't even have a way to compare our outcomes to each other. So AI sort of breaks down a lot of those barriers. And I think it's going to lead to the commodification of dentistry. And I know that's a bad word for dentists, but this is one thing that I say a lot. Gold is a commodity. Golden Corral has a service line. So even though, like we like to think of ourselves as service-based providers, we all should have standards. And that's something that, like I said, I think AI is going to really help usher in if it's in the hands of the right people.
Well, here's the argument the counter argument that I've heard from clinicians. Actually, we just had this conversation, Tanner and I, over the weekend, and with a dentist, is that the AI is only as good as the doctors who are inputting the information. So Tanner and I might be able to create the AI and say, here's this great AI that can benchmark different treatments, but Tanner puts it, there's a paradigm there. You
Right.
might be on the lower end of the paradigm of what you deem is acceptable, or you might be on the higher end of what you deem acceptable. And that's really just what I've been told is that's just an opinion, and there's really no way to splice that. What do you do with that?
So I think that's the first step is what data are we looking for? So the way I approach this is looking just at outcomes. If you do a procedure, what is your complication rate? Are you generating better outcomes than the average? And if you're generating outcomes better than the average, how can you quantify that? And then how can you distribute that data to the profession at large? Because yes, this is what's going to happen. The AI will undoubtedly select, or should be able to select, for the doctors who have the longest longevity rates. Their work lasts longer than anyone else. So when that's presented to a doctor who may not have the longevity rates, first you need to look at yourself and say, okay, my pattern of practice isn't what it could be. Here's a doctor who's better than myself. Using objective third-party data, what can I do to improve myself? And so that's just the first step, is for us to admit as individual providers that maybe the outcomes that we're generating in our own patient populations is not the best out there. And if it isn't, to be open-minded to say, okay, how can I learn from this doctor who is better than myself? What does that entail? So that's going to be the first thing. And that's one thing private practice dentistry has really shied away from. Like I said, once you pass your standards, we don't like to think, what happens for the next 30 years? Like, are you getting better in your career? Are you getting worse in your career? Are you just plateauing? Like, our goal should always be to get better. And I think that's where like this really comes into, and say, hey, let's find those guys. Let's come together to collaborate to say, okay, what are we looking for in the top 1% to 5% of doctors in the country, and can we replicate that?
Interesting. So my question on that is, if there's this shift of always trying to improve, obviously we all want to be in that 1% to 5% of outcomes, et cetera. But my question is across the standards in dentistry, should there be a bare minimum that is a higher standard bar than what currently exists, or what maybe doesn't exist at all, right? But should there be a bare minimum standard that every doctor should try and work to? And does that already exist, kind of, I guess, with the boards and such?
I would say that bare minimum standard already exists. Like,
okay,
you spend 4 years to get a dental degree, basically after college. Yeah, you spend number of hours to take a board exam to get licensing. So I think that bare standard definitely exists as it is. I don't think that we have it. And then now we'll have to also say there are CE companies, there are the Academy of General Dentistry, things like that, the Academy of Cosmetic Dentistry that will provide fellowship and to show that, hey, you're a better dentist based on their own standards.
So if I leave and let's say I graduate, right, meet that standard, I get my license, I go out and I'm practicing 10 years out, let's just say hypothetically there's a way to measure it, but let's say I'm the exact same as I was when I took that standard. In the industry amongst my peers, would I be considered a proficient dentist or would I be considered a mediocre dentist because I've only kind of met that medium or that bare minimum standard?
That's a great question. I don't think I can give an answer that goes beyond myself because that's something that we literally don't think about. So like, we'll put it this way. So if I talked with another dentist outside of a professional business conversation, we can be sued by the FTC for collusion, for basically anti-monopoly discussions. So we don't routinely compare ourselves to other doctors other than, you ask how many crowns you did. You ask, how profitable you were. We don't routinely know how to actually standardize our data to be able to talk about that personally. And it's something that is rarely done on the wide scale. Now, there are groups, obviously, due to my interests, I find a lot of those doctors, but that's not a common conversation for a group of doctors to have.
Got it. So then what is the current, just so everybody listening, what is the current way of measuring what is acceptable and not acceptable? Because there's a lot of treatment that I've heard dentists say, like, they shouldn't have done that treatment. That wasn't what was called for in this area. And then someone else will come out and say, no, that's exactly what they should have done because of X, Y, and Z.
Right.
And then from the patient's perspective, this is the patient going into the offices, they present it and say, I have a problem. I go to 5 different dentists. I get 5 different treatment recommendations. Is that wrong or is that right? Or is it just something that needs to be, again, standardized?
So there's a saying in dentistry, like, what works in my hands? Basically, it says you get to do what you do because it works for you, not necessarily because it works for anyone else. So there's a famous Reader's Digest article from, I think, the early 1990s that talked about a guy that went across the country, went to 30 different dentists, had treatment plans that range from $0 to $30,000. So like, you need 2 fillings to you need a full mouth rehab to like you need your teeth extracted. So it was all over the board. And that's something that we have known for 30 to 40 years. But it's something that we don't have the mechanism in place to actually verify, like, is there a right? So our standard of care is basically what would a prudent dentist do in your geographic area? You have a very wide range of treatment that you can offer, but there is no objective clinical standards of a tooth has a cavity of this size. What is the best thing to do? You can say,
how do you feel about that?
Well, I think it's a gap in the knowledge that needs to be explored. So I mentioned this earlier, and I'm going to just read. I was actually flagged for fraud back in 2018 by a large national insurance company. And basically they said our billing pattern analytics based on our claims data submitted for services for a 1-year period between 2017 and 2018, a total of 97,000 other general dental practices were analyzed, and I was determined to be submitting a greater proportion of large fillings than most general dentists. I did this 69% of the time versus most doctors did this at 24% of the time. So I would say
3 times almost.
3 times. I mean, out of 97,000 other doctors, as a baseline, there's roughly 150,000 doctors in the U.S. I don't know what size of their database this is. This may be out of the 97. This may be out of everybody. I don't know. Right. But I came back to them and I said, look, what is my complication rate? How many crowns? How many root canals? How many extractions? Like, how many of this am I doing? And they said they couldn't give me that data. They said it was their proprietary business intelligence, but I had been tracking this for myself for the last 5 years. I saw a reduction of 70 to 80% in that major work. So like, my complications decreased. There's no question about it. Like, objectively, they decreased. I did not have to do major work. I didn't have to do a lot of this end-stage dentistry. But even an insurance company with a very well-designed algorithm, based on some artificial intelligence from very smart actuarial scientists, didn't even pick up that I was generating better outcomes than this 97,000 other group of doctors. And so if we don't even know what those outcomes are we're looking for, then how do you use AI to standardize the data if we can't even agree of what the data that what type of outcomes we're really trying to generate? In my opinion, as a doctor, our outcomes should be creating healthier patients. And that's the bottom line are my patients healthier? Do they need less dental disease? But that is an entire different conversation as far as compensation systems.
Yeah. What happened with the fraud case? Did they end up dropping it?
I actually called them. It was a past dean of my dental society, my dental school that worked for them. I messaged him, hounded them relentlessly, talked to their guy, and I said, look, I sent him a portfolio of maybe 20 cases. And he said, this is obviously you're not doing a fraudulent billing pattern. And I said, well, if I'm not fraudulent, then what does that mean for the normal? And then it got very quiet.
So what's the conclusion? Just help us out. Spell it out for us. What's the conclusion if you're not fraudulent?
So the conclusion was I literally generate better outcomes than this 97,000 other group of doctors that I'm comparing to, but that the insurance company didn't understand what they were looking for. So do y'all play fantasy football or anything like that?
Yeah.
Okay. So if you don't know anything about football, could you read fantasy metrics and pick out the best football player around?
Maybe.
No. If you don't know anything about football, you probably don't know what the metrics mean.
Oh, I follow you. Okay, yeah.
Right. So I posted my cases to an actuarial science group forum that I found actuaries. Like I go deep down. And so the actuaries were like, don't show me your cases. I don't want to look at dentistry. It's like, don't show me blood. Like that's not what I do. So it's like, if you're an actuary, you don't have a healthcare background, how can you design an AI system if you have you're not a wet-fingered clinician, if you don't know what you're looking for? So the bottom line is there's not enough cross-training. There's not enough actuaries who have a background in dentistry. There's not enough dentists who have a background in actuarial science. And so until we actually develop a lot of cross-training to show what you need to do from a data point of view, what you need to do from an economic point of view, then we're never going to be on the same page. And I think that's where we are now. There's so much room for growth.
One thing that you keep saying, though, is you keep saying we had a better outcome, right? And I think that from my understanding of outcome has a timeline associated with it, right?
Correct.
So how are you able, let's say you did it for a year, you got flagged, they ended up saying, hey, by the way, you're creating fraud. How are you able to determine the true kind of long-term outcome results of what you did? Because I imagine, and this is just from my pure assumption, right? I imagine a larger filling is not going to last as long as a crown would in the same situation. Is that true?
One, that's not necessarily true. So the largest longevity study is out of Great Britain, and it's like 26 million restorations, a million different interventions of providers and patients, and they found crowns per se. Crowns, they tested longevity on two different metrics: time to reintervention, so how long did it last until how long it needed to be replaced, and time to extraction. So crowns had the longest to the reintervention. So they lasted on average 7 to 15 years. Fillings last 5 to 7 years. But the problem was crowns were the fastest to extraction, meaning as soon as you placed a crown, you're much more likely to have an extraction than you were to have a reintervention. So crowns were actually found to perform suboptimally if you're looking at how long does that tooth stay in the mouth. So this is why I talk about end stage dental disease. It's a terminal event for a tooth. And so if you place a crown in a patient population that's a little younger, you're actually increasing the likelihood that that tooth gets extracted prematurely. So that's a great question because you have to make that differentiation when talking about outcomes data.
Yeah, because that brings in what do you do if someone how do you factor in how much money someone has? How do you factor in their overall health condition and their diet and their age? Like, how do you, that to me, it's just like daunting to even try to figure that out. But I think that's where the AI comes in and helps you solve some of that.
Correct. So I've actually, what I'm writing my thesis on for this Masters of Health Science program is an epidemiological index. Basically, it's just a number. So say you come in with 5 crowns. So 5 crowns cover 5 surfaces. So that's 25 surfaces of dental disease. So your number is 25. Say you're 25 years old. It took you 25 years to gain 25 surfaces of dental disease. So you have an average dental disease progression of one surface per year. So everyone has a risk. This goes back to that fantasy football. Like, are you good in the fourth quarter? Can you hit the game-winning shot? Or are you, a guy that plays better at the first part of it? So everyone has a dental risk. We just don't really talk about it. And then every doctor has their own risk. So if you come to me and you have that progression of one surface per year, and I treat you for 10 years, then it's expected that you should have an additional 10 surface of treatment needed. Well, what happens if you don't need any other surfaces? Then that means in the time frame that I was treating you, you have a lower disease progression in my hands than you did in another period of life. So it also goes into, where are you in your career? Where is that patient in with your life? So an older patient, we know, has a higher risk of developing cavities because of different medications. We know teenagers have a higher risk of developing cavities due to their lifestyle behaviors of not cleaning so well.
Eating Sour Patch Kids and not brushing their teeth, stuff like
completely.
that. Yeah.
But
Gary,
it can
your
all be
background?
quantified.
Yeah, I totally.
For yourself.
This is the only part of the conversation I actually understood. So
Sour Patch Kids.
Right. So everyone has a number. Everyone has a degree of difficulty, just like gymnastics. I mean, what is the degree of difficulty? How many points did you accumulate, and what are the modifiers? So it could be done for dentistry. It's just something that we haven't really set down and done on the large scale yet.
So let's say right now, obviously, these AI companies, they are constantly being fed right now. I can't imagine that they have this huge amount of data they're pulling from right now. I don't know. That could be completely wrong. They could have access to some existing data, right? But purely based off of the number of offices that they're in right now, that I would say have active AI capabilities, et cetera, I'm interested to know, okay, so obviously this what is the standard right now based off of these AI, what they're outputting is going to constantly develop and evolve the more and more information and data we feed it. Okay, let's say that we get to a point where, okay, they've got enough data where we can say, okay, across the industry, this is the average, this is the norm of where things should be. What do we do whenever my assumption is, okay, it's going to be based off the median, right? Wherever kind of it falls based off of that. You've got those that are better than that are going to look at it and say, oh my gosh, I would never do that in this situation because I know that it's not going to give me the outcome, right? Those are the higher percentage people, right? And the lower percentage people are going to look at that and say, oh my gosh, I would never do that because I feel like that's invasive, even though they probably don't even realize that they're below the standard of care, right? And so what do you do at that point when you have this kind of group of people that may probably not even ever come together and say, hey, this is where the standard of care is. I agree to it. I understand it. And therefore I'm going to work with that. I mean, is it kind of a futile thing where it's always going to be left up to the dentist to decide, hey, this is where I'm going to be and this is where I'm going to practice? Does it not influence it at all?
Oh, no, that's a major influence right now. There's no question. And so I'm going to touch on this value-based compensation. And here's the second part of it. It's like, we know certain procedures are more profitable than other procedures. So if you're doing a procedure that's highly profitable and you have a question, you don't even realize you're being pulled to those types of procedures. And so that's what happened with me. The only reason I did this is because I actually had to redo my entire compensation system because I was paying myself more for these basic procedures because I couldn't take insurance anymore. So if you have this situation, you have to come together as a group. That a DSO group would be a great functional unit to first talk about this. Is like you get a group of doctors in the room and you talk about what is our philosophy. We want to have patients in the chair for as little as possible. We want to have the best outcomes. We want to have more teeth in our patient's mouth than the guy down the street. And if we want to do that, what does it take to do that? And if the senior doctor has 80% of his patients have 80% of the teeth, and the junior doctor only has 50% of their patients with 80% of their teeth. And, the junior doctor has space to improve. And this is a big, not even ethics. It's like a personal accountability type thing. Is like, when do you look into yourself and say, I can be better? And that's a whole different argument than forcing doctors to accept someone else's treatment. Is to say, how can I look at myself and just be a better dentist, and what would that entail, or what would I think of that or what does that look like for myself? And so I think that's the first step, is to get doctors to think inward and say, if I was a better doctor, how would I think my own pattern of practice would change? And then we could have a more in-depth conversation from that point of view.
Got it. So how do you see this rolling out? What do you anticipate happening based on the knowledge that you have and understanding how dentists think and how some of these organizations are formed? How do you see this happening? Give me the 10, 20-year picture that you see AI rolling out and how standards are going to be set in dental and maybe even in medical as a whole.
So first of all, there's an area of research called comparative effectiveness research, or patient-centered outcomes research. The federal government, through Medicare, has been looking at value-based compensation. So currently, as a doctor, it doesn't matter if you do a filling in the last 5 years to 7 years to 15 years. You're getting paid one time, and that's it. We're looking at ways to pay doctors for the quality and the longevity of their restorations. So the federal government has stated we need to rethink the entire compensation system. So that's coming. There's no question that's coming. That's the push. So it's going to be here. I think AI.
And what does that do exactly? So for somebody like me that understands, I know what pedo Medicaid is, right? I understand it from the marketing perspective, but how is that going to impact the industry? How is that going to change how DSOs operate and groups operate?
So I'll make it really easy. So think about it this way. So say you go to one doctor and they say you need the crown. The crown is $1,000. That doctor gets paid $1,000 to deliver that crown. Okay. Say you go to the second doctor and the doctor says, you know what? You don't need anything. You have a very small filling. We can place silver diamine fluoride or some other minimally invasive intervention, and we avoid that crown for 15 years. That doctor may only get paid $60 for that intervention. So the question is how do you pay for the ounce of prevention that avoids the pound of cure? And so it is a complete different mindset of pay more for prevention, and everyone has to understand that it's going to have to be higher fees for more minimally invasive options. But the doctor will now accept responsibility of avoiding that dental work for a specified period of time. So if I don't have a way to get paid for not doing anything, then this is never going to go anywhere. And that's the bottom line, is how do you pay a doctor for avoiding disease versus treating disease? And that is something that we in America don't have a grasp on, and that we can't come to terms with.
We just want to take a pill for it, right? And to keep taking the pill, and then you take another pill for that pill, and so on and so forth.
Correct.
So that's the Medicaid side from the federal government side. What about, and that obviously is going to affect some change, but who knows how long that the government takes forever to do everything, right? So that if they're listening, you can tell them I said so. And then what about on the private side and the DSO side? How do you see that?
And in the insurance side,
and then the insurance side,
So I'm going to say I'm a radical in this area. So I actually think there's a way to pay doctors to avoid dental care by giving them a direct access to the membership premium. So like if you think about a dental insurance company, if they aggregate the premiums, they invest those premiums for a period of time, and then they pay out the benefit when the patient has disease. So if you reduce the volume of dental care that your patient population takes, theoretically, a dental insurance company will make more money in the long run because they don't have to pay so much out in benefits. Obviously, there's medical loss ratios, this, that, and the other. So what happens if patient or providers themselves actually had basically a direct interest into how much money that insurance company made on reducing the dental disease? So I don't accept insurance anymore, but I have my own dental plan. And so I'm big into what's something that's called as a risk-bearing provider entity. Basically, I fund my own dental insurance for my patients. And my goal is to make just as much money on my membership premiums as it is on services. And so I audited myself last year, and I made more money on selling dental insurance than I made on selling dental crowns. So I'm now making more money on the prevention because I'm learning how to manage that patient's risk to the best of my ability. So I actually think a radical approach is to literally rethink insurance completely and say, you know what, a DSO, especially a sizable DSO, a 30 to 50 dental practice organization can sell an insurance product directly to patients, and you can explain to the doctor, your goal is not to make money on doing the crown. If you avoid the crown, we can provide you a benefit that we're going to give you a little bit of a profit sharing agreement that you get paid for not doing the work. And so I would say, how many doctors would love to do a very intensive full mouth rehab and get paid, say, $15,000? Or how many doctors would love to do hygiene checks, get paid the exact same amount of money? You don't have the physical strain on your body. You don't have the risk for doing a very intensive procedure, and you come out better. So I think you just have to rethink the compensation system and pay a doctor based on the premium pool, which is something that is, like I said, I think this is an area that DSOs could rewrite the history of dentistry going forward if they would consider that.
Interesting.
Yeah, that would rewrite like medical as a whole, right? Like that would
completely.
Yeah, because
so
I mean, right now, like I've had health issues where I go to the doctor and I had like digestive gut problems, and it was largely could be fixed by diet, and they were just like, we don't know. Here, you know what I mean? Or here, take this thing.
Right.
And I'm just like, no, I don't think that's the problem. And it was kind of like, all right, good luck. And I had to, test and like fast and then add foods back in. And it was very complicated, but they had no interest in like solving the problem. They just wanted to kind of move me along. And so I can totally understand that from a patient standpoint. And
let me interject real quick. I think this will clear it up. So there's a model right now called direct primary care. So it's sort of like concierge medicine, but it's concierge medicine for the masses. So with the idea of direct primary care, you pay a doctor a membership fee. Say it's $150 a month. You now have access to unlimited visits. You have access to testing at cost. And so that doctor's goal is to keep you healthy. If that doctor can keep you out of his office, keep you healthy and happy, collect their $150 a month, they can see a larger patient population because they're now getting rewarded for providing health. So it's something that has been done successfully. And actually, I believe it was Amazon or Google just purchased a direct primary care group for like $3.9 billion. It wasn't a large group. It equated to like $8.5 million in valuation per doctor. So if you imagine a four practice DSO, not a four practice, a one practice DSO with 4 doctors is now going to get valued at $36 million. If you have that type of financial incentives, I mean, you're going to start looking to ways to implement this, because that's the way to be making money on
it's better for everybody
type of model.
Yeah, it's better for everybody.
Right. Except for the people who make money who aren't involved.
Yeah.
Right.
Yeah. So how do we move forward? So right now the what I keep hearing is in my head there should be some kind of range. Like, this is bad, this 20% over here is bad, and this 20% over here, 10% over here is really good. Right. And then you have your normal stuff in between. But then what I keep getting told is you can't say that about the edges. Because you don't know all the particulars. So if I can't know what's good and bad, patients don't know, right? We have no idea if we get good or bad dentistry. Only if did it hurt, and then we'll find out in a couple years, right? And so, so how do we start to close those gaps on the edges of what is good and bad dentistry?
I think this conversation is in exactly the first starting point. I mean, you have to have the conversation that there is good and bad. There's no question. And that's a conversation that we have avoided for a long period of time. So the data says basically in the last 30 years, there hasn't been any appreciable increase in outcomes data, even though we have better materials, we have better knowledge,
better technology. You have technology doing the stuff for you.
For us. So if we have to admit that, the first thing is to admit it, and then to have some serious conversations. And then what I think is for us to get out of the academic mindset. So this goes back to COVID and academia as a whole. So there was a doctor back in the early part of COVID who was using an inhaled steroid and was basically chastised for even bringing up this medication back in March of 2020 because it was experimental. There was no official research data. a year or two later, Oxford University did a randomized controlled trial and actually verified that this doctor was generating outcomes that were reducing his severe complications by like 30%. So the data was already there. You just have to go into the doctor's office and say, look, the best data in the country on the outcomes is on the shelf of every doctor's office in this country. And it's a vast amount of data that has just been overlooked. AI opens that up. And I really think AI is going to provide us a window into the best and worst doctors' offices. And when you start looking at it, I mean, I would love to get my hands on a lot of that data. You can parse it out. I mean, it is definitely there. I think with this, I think DSOs, and DSOs have had a very bad rap in dentistry because the idea of corporate dentistry, this, that, and the other. I think this gives them an opportunity, like to highly increase the standard of care, because they have access to data that a single doctor like myself don't have. If you can find the number one doctor and you're a DSO, that is a huge step forward. And if a DSO said, you know what, I would like to publish this, like, they could do it. And just that in and of itself, it would change greatly. So I'm going to tell you a story about one doctor. I'll make it really quick. This guy's name is R.V. Tucker. He's known for this gold study. One of his students, who was a professor at University of North Carolina, before he died, went and did a study on his patient outcomes. He found at 20 years, think about this, 20 years, 72% of his work was still in the mouth of his patients and in good condition. So 72% of his work lasted 20 years. The average, 50% of our work in the United States lasts less than 7 years. So that's the difference. 72% of our work could last up to 20 years versus 52% of our work, or 50% of our work, lasting less than 10 years. So if we find doctors like that, like, get their data out there so we know what we're looking for. I mean, and I think that's the first step.
Yeah, it's so basically the AI needs to roll out. That's going to create some kind of something. It's going to create just benchmarks somewhere, because we don't even have those benchmarks of good and bad right now. Get those benchmarks. Oh, look, you're in the top 20%. Oh, look, you're in the bottom 20%. And then from there, that's when the real conversations are going to start happening. Right. So are we 10 years out from that happening, or?
Well, so this insurance company flagged me in a 12-month span of time. So in 12 months, they knew I was completely off the board. So
okay. So it could start happening in the next couple years.
6 to 9 months. I mean, So if you think about a timeline, if you have access to segments of that timeline, you can piece together the entire timeline in a 1 month span. What does it do? What does a dentist do when they're presented with this type of treatment? What does that dentist do when they're presented with a more advanced treatment? What does a dentist do when they're presented with very advanced treatment? So you can literally, in a span of 1 month, if you have 5 years worth of data from 10 doctors, you can piece together an entire timeline of that DSO and know instantaneously, what's the AI companies, are they going to release this information? Are they going to come out with it, or are they going to be worried about coming out with it? Yeah, they have to, because I don't think the DSO is going to come out and say, hey, here's what we're doing. Let's compare to all these other DSOs.
So the other companies that obviously have access to this type of data are the insurance companies. And there's a reason why the insurance companies haven't released this, right? And so what is the financial protection that they're doing where they don't release it? And is AI going to run into the same thing where they're like, hey, you know what? We're not going to make this a public, like, we're not going to die on the sword of trying to make sure that all the standards are improved.
Correct. So I think one thing we also have to realize with a PPO group, there is a certain aspect of liability. So I, as a doctor, have more liability than anyone else that you talk to as far as when it comes to providing dental care. DSOs are isolated and protected. Same thing with insurance companies, and same thing with other third-party payers. So as an insurance company, if you're going to go out and say there is a difference and you recommend a doctor based on that difference, then you're accepting a certain amount of that liability from the data that you've generated. And when I presented this to an insurance company said, look, there's a certain aspect of liability that we don't want to take on by recommending a doctor based on the quality outcomes, because we're not providing that service themselves. At the same time, if an insurance company primarily makes a lot of money or makes their money on the size of their network, do they necessarily want to reduce the volume of their network by 20% to drive out the worst doctors? So it goes back to those financial aspects. And that's actually why I went to get my MBA before I got this Master's of Health Science, because there's sort of a saying, if you're not making someone some money, like if you're not, you can't do good by not doing good. You know, you've got to make it profitable for somebody. If you don't make it profitable for somebody, then it doesn't go anywhere.
It won't get done. Yeah.
Right.
Correct. So that's a whole nother argument. Like I said, I think if you're a DSO and you're an AI company, you need to be thinking, man, what happens if we just replaced some of these large insurance companies? Because an insurance is only an algorithm. I mean,
yeah,
that's all we're talking about. It's just a simple algorithm. So,
yeah, that's a great point. Is there anything, this has been really, really good. And I think it's a great first conversation. And basically in my head, I'm like, okay, well, we're going to have this conversation every 6 months and just see what happens. Right. And if we keep talking about it, eventually someone's going to say, hey, no, we do have a bottom standard, or we do have the top standard now. And it's in this window that we know of. And then from there, then it's going to just continue to create those benchmarks. Right. And it sounds like it's going to happen sooner rather than later. Someone's going to find that hole and kind of run through it. So I'm looking forward to that. And I appreciate you reaching out and just saying, hey, this is something that I'm interested in, and this is something that I'm studying. And it's very, very enlightening, because you're bringing a whole nother perspective that we just couldn't wrap our brain around.
Right.
So is there anything that we didn't cover today that you think that we should cover?
No, I think this is a great introductory. I mean, like I said, you could run down every rabbit hole that you want to talk about. And there's so many different aspects of it. You know, like if I wanted to advertise, so from you're talking about marketing, what happens if you have a DSO group come to you and say, you know what, Gary, I just want to advertise that the outcomes that we're generating are better than the 5 guys down the street. So that's what I first started, was advertising my own cases as second opinions, and did free second opinions for cases that I thought could do better. And it grew my entire practice. So you
can't even say you're number one. You can't say the number one dentist of XYZ.
Right.
They're like, nope, can't say that because you can't prove it.
But you can prove a difference if someone comes to you with a treatment plan. You can show the difference in the procedure, the quantification of the procedure, and what you did there. So
it's going to be super fun. There's going to be a lot of ticked off people when you start marketing.
They're definitely. But that's the way revolutions happen.
Yep. That's awesome. Anything else, Tanner? Any other questions?
No, this is really awesome. This is super helpful.
Well, can you do this? I know we're connected online. If the next time you hit a milestone and you go, okay, now we got this next thing, would you mind just poking us and we'll have this conversation again?
For sure. Thanks for having me. I appreciate it.
Absolutely. Thanks so much. We'll make sure. And if someone has questions for you, are you willing to talk to people and have
completely. If I don't know the best way to get my information out there, I don't know if you post on your.
Yeah, we'll post it on the video, but just share it here for those listening.
Yeah, so the best way to get a hold of me is through my dental office, as Azalea Dental Care. And then my email is first initial, last name, M. Gillespie, GILLESPIEDDS @gmail.com. Open book. You can Google me. I'm out there.
That's awesome. This was a great conversation, and I look forward. I'm really excited that we're going to get to talk again. Maybe it's 6 months, maybe it's 9 months, maybe it's a little bit longer, but I'm really looking forward to the next step and how this starts to roll out.
Yeah, thanks for having me.
Thanks, Matt.
I appreciate it, guys.